Hello, everyone. This is Jacek Spendel. I'm president of Liberty International, and I have a privilege to run another. This is a fourth consecutive public Zoom meeting. Today we have a wonderful guest, Dr. Dave Vequist. I will introduce Dave in a moment. But before, I want to make a few announcements. First of all, welcome everyone. I see we have a good number of people watching us here on Zoom. Now they are getting from the waiting room to the actual meeting place. And we also have people watching us on Facebook. This is available on Liberty International's fan page. Liberty International is the host of this project, of this Zoom meeting. So a little bit about our organization. It was formed back in 1969 under different name. Society for Individual Liberty joined in 1983 with Libertarian International, and we were functioning under the name ISIL, International Society for Individual Liberty, and a few years ago renamed to Liberty International. So long history. Hello everyone. I see Zoom took a little bit while for moving people from the waiting room to the actual room. So once again, welcome. I'm just making a little introduction of Liberty International, my organization that is hosting this project, the Zoom public calls. We spread ideas of freedom around the world. This is our main mission, and we educate young people, especially newcomers to libertarian ideals. We have a number of different projects, with the Liberty International World Conference being the biggest and the oldest one. We have a leadership program for young freedom leaders in Phoenix, Arizona. It's called Project Arizona, and I welcome everyone. I see lots of people here. I know many of them are young and students. So check out projectarizona.us. We are recruiting for 2021, for class of 2021. And this is pretty exciting project. We also have something brand new that you will hear very soon. It's Libertarian Solutions online course, 16 webinars. But you will learn more about this project soon. I don't want to take too much time talking about our various projects. Basically, we are spreading the ideas of freedom. We are spreading the libertarianism, and we do it globally, especially in less fortunate places. We are making a bridge between the Western world and the less fortunate parts of the world, helping them to understand these ideals and to promote freedom and prosperity. Now I want to introduce our amazing, wonderful guest. It's Dr. David Vequist. Dr. David Vequist is joining us today from San Antonio, beautiful San Antonio in Texas, in the great state of Texas, formerly independent state of Texas. David Vequist is a founder of and director of the Center for Medical Tourism Research, CMTR, the first academic research center devoted to medical tourism research. He is also a tenured full professor of management in the HEB School of Business Administration at the University of the Incarnate Word, UIW, in San Antonio, Texas. Before that, Dr. Vequist was an executive for Methodist Healthcare, billion-dollar healthcare system in Texas, and consultant for Ernst & Young, LLC. He is an accomplished speaker, author, researcher, and futurist on the topic of healthcare trends, medical and retirement tourism, health technologies, social media analytics, training, development, leadership, and technology management. He has presented on 5 continents, consulted with Fortune 500 corporations, NGOs, countries, and has produced numerous articles, papers, book chapters, been interviewed in many publications and channels. And very recently, only a few days ago, he was covered in a New York Times article on the state of medical tourism during the COVID pandemic. And we published this article on Facebook on the event page. You can check it out. So once again, welcome everyone. I'm very delighted to have you at this Zoom call hosted by Liberty International. David Vequist is our guest. We are recording this meeting, and you dear audience, you are more than welcome to ask questions. They can be asked three different ways, either by email, spendel@liberty-intl.org, or here on Zoom. Just you need to put them on chat, or the third version for the ones who are joining us through Facebook, just ask your question on Facebook. First half of this meeting, next 25 minutes, it'll be me talking to Dr. Vequist, mostly him answering my questions, and then 30, maybe 40 minutes of questions, answers from you, dear audience. So let's start it. Let's have it rolling. Dr. Vequist, once again, wonderful to have you. Great article. I saw you had this New York Times article that came about a week ago, and it's about your very recent research you took on medical health tourism. Can you tell us a bit more about it?
Yes, thank you, Jacek. And before I get started, I just want to let everyone know, thank you, both Mandy, who's handling the administration of this, Jacek, who's just a terrific person, a terrific leader of Liberty International. And please, everybody listening, please support both Liberty International, Project Arizona. I've been proudly involved with them for many years. It's a terrific organization that's helping a lot of young people around the world learn about freedom and free markets and liberty beliefs around things like healthcare. So the New York Times article was an interview of myself and a couple others based on some research that I'm doing about how healthcare systems are investing in the idea of having guests come from out of town, from sometimes out of the country, and stay at their facility for a multiple day period. So some of the best healthcare systems in the world, particularly those we in the New York Times article, we were talking about the ones that were happening here in the United States, are actually investing in hotel and hospitality resources, facilities, hotels that are attached to the hospital, things of that nature. And it's actually an interesting aspect of the hospital because it's actually a little bit more profitable than many procedures that are done in the hospital. So it's an additional revenue stream that's also highly profitable. And that was essentially what the article was about. And what was interesting is, again, the COVID-19 is not only hurting hospital revenue in terms of non-essential types of procedures that are being done, but it's also hurting them in terms of this hospitality revenue. But we expect as things get more normal that the revenue will continue for these centers of excellence.
Thank you. So what is basically the area of your research, and what is the relation, how does it relate to free market trends in healthcare we see today?
Oh, that's a great question, because the most interesting thing is when I started on this research around medical tourism, I knew that people were traveling to healthcare. They were making choices about healthcare based on a variety of different factors, but mostly a combination of what Michael Porter from Harvard would call basically quality, which is both the cost and the quality and the access and all that, value is what Michael Porter referred to it, is value. And as I started researching it, not knowing what the state of the world would be, I found over and over again evidence that most medical tourism, health tourism, retirement tourism, even places that are sought out by consumers, tended to be private organizations. Not all private for-profit, some private nonprofit, but the majority of them tended to be private organizations. And so that when this kept coming up, I started making it a bigger portion of my total research was to look at why are people traveling to primarily private facilities. Here in my wonderful hometown, current hometown, I should say, of San Antonio, we actually have a facility that is one of the largest, I should say, it is part of the largest pediatric rehabilitation facilities in the world. And it's actually a nonprofit entity out of Mexico that anybody from, most people from Latin America and almost anybody from Mexico knows of, which is called the Teleton Children's Network. And they're a nonprofit, and they're considered one of the best places in the world to receive health care at for particularly children with disabilities or children recovering from cancer oncological treatments. And it's a nonprofit, and it's funded by both the revenues it generates, and it generates quite a bit of its revenue from people that are out of the local area. So not just local residents, but people from throughout Mexico, throughout Latin America, even people from the United States travel down to Mexico. And so because of that, they decided to build in the United States as well. And now supposedly they get people traveling from all over the 50 states just to come here to San Antonio, Texas to take advantage of this private pediatric rehabilitation facility.
So it sounds that this sector of healthcare is flourishing. It has a lot of good potential, yet there is a lot of critics who are citing a lot of negative aspects of especially for-profit type of healthcare. How do you respond these critics?
Yeah, so the first thing I'll tell you is, unfortunately, oftentimes the media and the healthcare media are not your friends. They're going to tell you things that they believe to be true, and that sometimes they'll give some partial evidence to support it, but not all of that is true. One of the things you'll hear, so you'll hear, particularly for those folks that are international, Jacek, I don't remember if you were on the bus when I got this question, but when we were in Mongolia together, we had a young lady from the Ukraine that was speaking to me about healthcare in the United States, and she said, well, you don't have full coverage for everyone. Aren't there people dying in the streets in the United States due to lack of health care? And, I was there with a physician that also studies the healthcare industry, and we chuckled a little bit because, that there are people that believe that in the United States that healthcare is not readily available to people. So let's go over a couple of the sources of evidence, for example. Some of you may be aware or have seen, and you can find this all over the internet. You won't find the actual evidence that shows it's untrue. It's very harder to find because it doesn't make a good story. But one of a former presidential candidate here in the United States, Elizabeth Warren, who's also a faculty member at Harvard in their law school, had written an article many years back that showed that people in the United States were going into bankruptcy at very high numbers due to medical billing. Well, it turns out that if you go into that research, and there's several pieces out there that have been done and very good legitimate journals such as Health Affairs and others, and the American Enterprise Institute actually did a piece on this that shows that that's a myth. First of all, the way in which they asked the question was the self-report. They basically asked people that had $10,000 or $50,000 worth of credit card debt, and then they also had medical debt. And they said, "Why did you go into bankruptcy?" And they didn't say, "Oh, it's because I bought too many shoes." They said, "Well, I went into bankruptcy because of healthcare costs." And so there was an assumption already made that healthcare would be a major reason. But one of the bigger numbers which came out, which is fairly obvious when you look at it, if you compare the United States versus Canada, which has some similar demographics in comparison, and very similar types of consumerism and cost of living and other things, the number of bankruptcies in Canada is actually slightly higher than it is in the United States, despite the fact that, according to some, Canadians have free healthcare, which is paid for by taxpayers. So how is it that Americans have lower bankruptcy rates than Canadians do when supposedly the number one reason for going into bankruptcy is billing, healthcare billing costs? So that's one of those things that you're going to hear about. The other thing is around high costs. You'll hear that in some places, whether it's Switzerland or the United States or Brazil, where there tends, or even places like India, where it tends to be higher levels of private facilities. Some people say that leads to higher prices in healthcare. And actually, there's a really great blog that's done by a person named that goes by the title of Random Critical Analysis, randomcriticalanalysis.com, that showed repeatedly in several pieces of information that actually our costs are actually, in comparison to Europe, are actually similar to what you would pay in Europe. It's just that Americans have much higher levels of disposable income. We actually have much higher asset levels. Our houses are bigger. We own more cars. We have more ATVs. We have more televisions. We have more gaming systems. We eat out more often. And so if you look at, in comparison to our lifestyles, actually our healthcare costs are not as high as you would expect. They're still somewhat high, and there's things that we can do to decrease that, but it's not as bad as you think. Other people say,
thank you for bringing lots of arguments that we do not often hear in public discourse. Medias don't talk about it. They only talk about, bills coming from these hospitals and, the end of the story. So talking about the private healthcare, what are the future trends in this area? Do you have any predictions in that matter?
Yeah, actually, a few of them. So one of the amazing things is that we've seen that private healthcare systems typically have higher levels of outcomes, better outcomes than public facilities. And that is increasingly being made aware of. And so you're seeing investments, particularly in developing countries, in places like China, the largest number of investments and the fastest growing investments in healthcare is in private healthcare facilities. If you look at the data, private healthcare, whether it's pharmaceuticals, Dr. Mary Ruert, a very well-known writer around government intervention and FDA policies, suggested that the FDA over, I think it's a 30-year period, potentially led to the deaths of millions by not allowing certain types of pharmaceuticals to be available. There's been, I apologize, looking over here, there's a couple reports that have come out over the last few years from Australia showing that 5-year survival rates between private and public hospitals are significantly different. And in fact, the major difference in death rates are due to whether you're in a private or a public hospital, private being better. Not too long ago as well, 2015, a mortality outcome analysis done of private and public facilities in Chile determined that private for-profit and private nonprofit outperformed public entities using comparable population data, comparable patient data. The reason why they found that they believe this to be the case is because incentives, essentially simply something that economics has been telling us for years, incentives matter. And physicians that are at private facilities typically do a better job for their customers because they want to stay working at the private facility and also because they want those customers coming back. And interestingly, in Chile, the physicians typically work in the public and the private facilities, typically have 2 jobs, but yet their quality was better at the private facility. In other words, incentives matter. National Cancer Registry report from Ireland in 2019, again, showed adjusting for patient age, gender, stage of cancer, wealth, and all that stuff, that in most cases of cancer, private facilities are better. The other things that we're seeing is, for example, in the United States, self-insured companies like Walmart and Boeing and Lowe's are investing in their employees' healthcare by sending them to centers of excellence. So the future of healthcare thank you for asking, appears to be private. It appears to be free market-based healthcare, where there's these multiple facilities in an area that compete for the business of consumers. And part of that competition is trying to become the best you can be, to be a center of excellence.
Thank
So
you. Thank you, David. I want to remind everyone we are having a public Zoom meeting hosted by Liberty International. Our guest is Dr. David Vequist, who is specialized in private healthcare, also medical tourism, and talking about healthcare. We can't miss what we have in our topic, which is the COVID-19. So does free market offer anything significant during the current pandemic? Are there any interesting trends, free market trends that the COVID-19 pandemic unleashed?
Yeah. So one of the things that's come up quite frequently, and people around the world are seeing data, and they believe that in, for example, the United States, which has high intensity of private healthcare, Brazil, which has fairly high intensity of private healthcare, some of these places, they see large numbers and they go, well, obviously capitalism has failed because there's these large numbers of COVID-19 cases there. What you have to do is look at the death rates. If you look at death rates as a ratio, population and death rates per million, for example, and you compare some of the countries, I have a paper that will be coming out on that, on the death rates for countries that have higher levels of private intensity, are actually very good. So many people have said, well, the United States, I hear you have a lot of cases. In fact, you have the most number of cases in the world. Well, if population statistics, let's look at these. So as of 2020, the largest country in the world is China, but we all know that the Chinese numbers, we can't trust those. So that's obviously very clear that China's numbers can't be trusted. Next largest country in the world is India. Well, we know that India, even if they were trying to test as many people as they can, they don't have the infrastructure to do that, and their testing numbers in terms of death rates would be very inaccurate in many cases because comorbidities and other things. So we can't trust numbers from India very well as well. So that leaves the United States as the third largest country in the world. And then let's look at who's behind us in terms of population, in terms of number of total COVID cases. Indonesia, do we expect Indonesia to report to be very accurate? No, most people don't. Pakistan, no, similar problems as India. We don't expect numbers coming out of Pakistan to be very accurate. Nigeria, that's the sixth largest country in the world. Do we expect Nigeria to report good numbers? No, we don't expect that. So then we have Brazil, which you saw spiked a while back and has a large number of cases. After that, Bangladesh, Russia, never know what you're going to get out of Russia. Could be good numbers, could be bad. And then we have Mexico. And so when you hear some of these numbers, you have to realize that one of the most important things is death rates. Death rates, if you look at the COVID literature, is really dependent on the intensity, the quality intensity that's in the hospitals. In the United States, we have a mixed bag of that, for example. So places like New York, where the death rate was very high, they have what's called a certificate of need, which has restricted and actually decreased the number of ventilator and high intensity hospital beds in the state compared to the growth of the population. And the other thing is that we see in terms of trends around the world, we see that like Germany, I had this report from the NHS, the death rate per 1 million people is 4 times higher in UK than it is in Germany. Germany has, it's almost, I think 68% of the total facilities are either private or private nonprofit. They have a less decentralized, more decentralized testing environment outside the hospitals and private laboratories. And that's allowed Germany to conduct as many as 150,000 tests per day, whereas in the UK, and this is a report from in 2020, just a month or so ago, UK was only managing less than about 10,000 a day. So the intensity of the NHS and other public infrastructure in terms of healthcare was put to the test during the COVID virus, and we found out that private healthcare was better at keeping people alive, which is what the research typically shows.
Yes, thank you for this, especially NHS. There is so much evidence showing that the national health system they have in United Kingdom is not very efficient, yet people love it so much. Maybe they don't know anything else, right? This is the only system they have. They save some lives, so they love it. But let's talk about these systems a little bit. United States does not have fully private system. It also does not have a socialized medicine. In somewhere in between, it has a lot of critics, not only from the left who would like to see a single payer system, more or less, but also it has critics from the libertarian angle or free market angle saying that there is actually too much regulation, too much intervention, shortages of physicians because it's heavily regulated basically. And also the private insurance is not completely freedom-based system. However, it's still very different than the socialized medicine model many European countries enjoy, quote unquote, like NHS. How would you rate the US system relatively in comparison to the European systems, for example?
Yeah, so there's actually a fairly, there's some countries out there that are starting to put together systems that are improving on a daily basis. And the US is one of those. We actually, our healthcare is not as bad as people, particularly around the world, and many people in the United States believe it is. Some people say, well, our mortality rates. Well, mortality rates is a very poor indicator of the healthcare system. That's actually a better indicator of social determinants of health, which include genetic propensity towards certain types of disease or problems. If you include that, that's about 80–90% of all health outcomes. So it isn't just the healthcare you receive in the facilities, there's a lot of other things. Americans tend to be very heavy. Americans drive vehicles much more than almost any other country in the world. There was a really nice piece in Forbes a few years back. It was actually started by a professor out of Iowa, as I recall. And again, not something that you'll hear very often, but if you take the total fatal injuries out of the US system and all the other systems, the US goes from, at that point, it was like 29th in terms of mortality, life expectancy rate, and we would rise up to the at least first place in the world if you take out fatal injuries from all countries around the world. The reason is Americans drive many more miles. So Jacek, when he comes to Phoenix, Arizona, he can tell you that very few places in Phoenix can you walk to as you can if you were living in Germany or Switzerland or Japan or Korea or any of the other number of countries the US is compared to. So automotive accidents, and particularly injuries, fatalities associated with that show it's not true. Another thing is when you're talking in general public versus private systems, the public system, for example, in the United States and other countries, when you put it to a comparison, true comparison, and I've got a couple really interesting ones for you that most people haven't heard of. There was an opportunity back in, I forgot, it was the early 2010s to evaluate around the same time as the PPACA to evaluate the Medicare expansion in a state. And that was a public system in the United States, and to compare it versus the people that were typically cash pay customers and other ways of accessing healthcare, including nonprofit and pro bono work from hospitals and doctors. And ultimately, as reported in a New England Journal of Medicine article in 2015, it turned out that people getting access to Medicaid didn't really change their health outcomes. It turned out that they had the same health outcomes, even despite the fact that the US government would spend millions of dollars to cover people. It turned out that the coverage, public health care, didn't really actually help them. And then here's the most interesting one. I'm actually writing this up in an article, not very well known, so you guys are getting the scoop on this. We have such interesting disparities in the United States. We have a group of people that typically don't access any government services and do all their healthcare self-pay. And typically they do bundled payments and they negotiate with private hospitals and things of that nature. It's a group of religious separatists, if you will, called the Amish in the United States. They actually have a similar life expectancy to what we find in Native American populations. Now, that's actually not the whole story. Turns out Native Americans, which live on reservations, many of them, about 1 million of them, we'll talk about those numbers in a second, they actually have total health care covered by the government. So essentially, we have a group that doesn't take any government aid, and we have a group that gets complete health care paid for by the government if they wish to access it. And they have similar life expectancy. Well, if you look deeper into the numbers, we have a number of people in the United States. It looks like about, you ready for this? 66%, about 2/3 of the people that claim that they are Native American. It's a self-report system here in the United States. You don't really need to check on that. They claim that they're Native American, but they don't live on reservations. They don't live in the Native American territories, the Native American nations. So therefore, we have people like Elizabeth Warren that say she's a Native American, but she isn't a Native American, and they are claiming their healthcare outcomes along with Native Americans. So if you look at healthcare outcomes, truly, Native Americans have some of the worst healthcare outcomes in the Americas, and they have it completely paid for by government.
Yeah, I observe it many times, especially that Phoenix, where we do Project Arizona, and you visit us actually every year, which is wonderful. Dr. Vequist comes every year for our Project Arizona seminar, giving speeches, always funding lunches. He's amazing. But we are all able to observe how these Indian reservation develop. And it's just sad to observe that people who get so much support from federal government, they are more hurt by this support than helped. It takes their dignity away. It creates a system of disincentives. They don't have incentive to go out there and work or start a company. Some of them do this, and I have a big sense of admiration to people who, despite all these umbrellas of governmental support, they still go out and work on the free markets. But not everyone does, because government doesn't incentivize you, quite opposite. And this is all being done under the slogans of help, reparations, paying back the bad history, and so on and so forth. So the same government first discriminates you with, different application of laws, freedoms, and then it tries to fix it, but it fixes it with policies that actually hurts you even more. And I'm afraid this is not only Native Americans. This is the entire topic of racial divisions. The government wants to mingle one way or another, but it doesn't help. And the US system is, as you said, David, is a mix of different systems in reality. For elder people, for Native Americans, more like socialized medicine. For a lot of people in their working age, it's private in big portion, with some flaws, of course. So we finished with my questions. Thank you. You really did a great job answering them. I'm sure our audience liked it. Now it's time for them. They are already sending us questions. I will start with the first one in a moment. Just I want to once again encourage everyone to send these questions. You can do it here on the chat or directly by email or on Facebook if you watch it on Facebook, and they will come to me. Okay, let's start with them. First one from KSD Jason. What are 1, 2, 3 things government could have done liberty-wise that would have helped during this pandemic?
Fantastic. So some of the things that have been happening in the United States is if you notice that they've been overriding some of the regulatory barriers and constraints that hold back innovation. So for example, as I mentioned, Dr. Ruert, who may be in attendance with us, is just an absolute genius, wonderful speaker on liberty and understanding the pharmaceutical FDA process, getting out of the way. In other words, having government get out of the way and allow innovation in the free markets to develop the treatments and the vaccines is a terrific way to do that. That is a great way that government can help, is by not helping and getting out of the way. One of the things that could have helped quite a bit is in places like New York, where they have a certificate of need. If the government could have not gotten in the way, what's called cronyism, in other words, getting involved in the development of business, and allow if a hospital wants to go into an area, allow the hospital to go into the area. This is a new business. You don't stop burger places from coming in. Why do we stop hospitals from going in? In places like India, which are becoming in some ways more free market loving than the United States, if you'd say you're going to bring a hospital into India, they go, oh my gosh, that's wonderful. We'll give you a 10-year tax holiday. In New York, they say, you're going to bring a hospital in, we have to ask all the other hospitals that they agree that you should come in and compete with them. And guess what typically happens? They don't. And they also give money to the politicians to keep these types of policies in place. So cronyism is not capitalism, and that is one of the ways that it hurts. Last thing I would suggest is that typically consumer choice, being able to travel for better health care, whether domestically or abroad, is a big deal. And I know that goes against some of the things that government is trying to do. So for example, here in the United States and in other countries, what we've seen is trying to reduce travel back and forth across borders. Oftentimes that's what you need to do. In fact, there were several reports of certain countries that had more, for example, intensive care capabilities, more ventilators and things of that nature, making those available for citizens from other countries. So international trade, international cooperation, trade ultimately leads to better free market outcomes and better outcomes for all involved. So if you had to ask me three things, those would be the three things.
Perfect. Another question from Stephen from Phoenix. What is going on with flu cases during this pandemic? Did they stop reporting the flu, or are they mixed with COVID?
Oh, so Jacek was very wise when he brought up the words to incentives. So what we're seeing in some countries, particularly say the United States, is we're seeing that hospitals, because they were forced into abandoning non-essential procedures, what you would consider elective procedures. However, not all those are elective. Those are not things like necessarily gender reassignment surgeries. They're surgeries that you can put off because you perhaps don't want to be exposed to other people or expose yourself to other people during a pandemic. So the things that happened was the CARES Act, which government passed, is incentivizing hospitals to call things, even though they're mixed with other comorbidities, call them COVID-related deaths because of the potential of getting reimbursements for them. So you're going to see in the future, we already have some hints that this is going to be coming out from the CDC, interesting aspects about the government shutting down various aspects of the economy. For example, in the United States, we're going to see automotive deaths go down significantly during this period of time because people weren't driving. So there's going to be very different numbers that we're looking at. And yes, I suspect, as you've already heard and probably hinted at, that we're going to see that other types of deaths may have gone down during that period of time, including flu deaths during the COVID pandemic. So it's all about incentives. Hospitals are incentivized to do what is going to help pay them more so that they can take that money and invest it, more infrastructure or marketing to bring in more patients.
Yeah, I like what you said, that it's all about incentives. That's very true. Next question comes from Rich Demanovsky. Please address how a free market would handle the currently common practice, even in the US, of listing people who have died of heart failure or kidney failure with COVID-19 as their, quote, cause of death, end quote.
Yeah, so interestingly, the one of the most fascinating things when it comes to free markets around healthcare is we always have a lot of fear around free markets and liberty. The idea is, are we? Can we trust each other? Can we trust businesses to report what they know? So most of people around the world are familiar with the credit systems that have developed, both for businesses and for individuals. That's run through free markets. And what happens is companies report truthfully data about their consumers to a credit organization so that they can get good data back. Most businesses understand the basic concept of garbage in, garbage out. And so what you see is typically very good recruiting or reporting of data through private systems so that they can then make better decisions, better judgments about what to do, what types of investments to make with their capital in the future. Free markets work in a variety of different ways. Europeans will oftentimes point at the United States and say it has high intensity of free market solutions, and therefore people don't get access to care. Well, in probably one of the most common areas, one of the largest areas around the world of healthcare, which is mental health, do Europeans realize that the United States has higher rates of, for example, of children with autism, the amount of pharmaceuticals that they get access to? How are Americans accessing pharmaceuticals for children with autism when supposedly we don't have access to healthcare? The prescription rate is considered in the United States for children with autism, psychotropic and other types of drugs is about 40%, whereas the highest rate in Europe is in the Netherlands, which is about 36%. So people fear and they think, oh, free markets, we're not going to get access to what we want. We're not going to get the care we need. But typically those things it never works out that way. Free markets always rise up to deliver because that's what they have to do. If they don't do it correctly, they don't survive.
They don't. Next question comes from Michael from Facebook. There has been talks of giving businesses like restaurants immunity from civil suit if a patron contracts COVID-19 at their business. How would immunity of this kind impact the spread of COVID-19?
Great question. So I'm actually here in if you will, the hotbed of the legal argument around the what you would call tort reform in the United States. In many countries around the world, medical malpractice is not as big of a deal as it is here in the United States. In fact, actually, there's quite a bit of evidence to show that pharmaceutical sales, the prices of pharmaceuticals in the United States are due, and even healthcare costs are due in portion to the medical liability risk. And in fact, we bear not only the risk of medical liability in the United States, but also we bear the brunt of innovation cost for pharmaceuticals from many places around the world, particularly American pharmaceutical companies or companies that use the American markets. So in order to answer your question, which is basically, will these free markets, gosh, help me out, Jacek, will these free markets lead to more liability for these companies? In Texas, we passed tort reform, which means that it's harder to sue healthcare providers and healthcare entities in Texas. And we didn't necessarily see the number of the price of healthcare costs go down that much. Interestingly, there's some reasons for that, mostly because they were trained by medical doctors. They're at medical schools that may not be in Texas and that learned how to do business, say, 20 years ago before they become faculty. And so they're still teaching doctors the old ways of doing it. So they're the ways that physicians are coming out of school, they're not really trained to be good at risk management around reducing the cost of patients. But one thing we did see in Texas is that when you decrease the amount of regulation around doctors, doctors are more willing to come in and invest in your region in order to develop better healthcare. So I'm kind of answering your question, but in an odd way. Typically, if you, I'm not opposed to being able to sue medical facilities if they do bad work. What I am opposed to is if the are getting together and what they're doing is they're spending money buying politicians and buying policies, which then further restrict the practice of medicine. And that leads to typically the physicians going away. In other words, they won't continue to invest and develop new businesses. They won't even try new procedures if they are overwhelmed by the legal aspects, particularly if the legal aspect is backed by a state.
Thank you. Next question, and for now it is the last one. If we get some more, I'm happy to read them, but at the moment this is the last one, coming from Brandon Flores. The average cost of a broken bone is $2,500, non-surgical and without insurance. For Americans working minimum wage, this amount is more than they will make in 1 month. How is this amount not bankrupting them for such a common injury?
So first of all, it's a great question, and unfortunately the answer is complex. One of the things that is always difficult when you're dealing with business areas is people that are consumers, people that have been to a Walmart or been to a store or purchased a car or a computer. They assume that they're now an expert in business and they understand everything about a business. In healthcare, it's very difficult and it's very complex, and you don't know enough about the questions that you're asking. So supposedly a rate that you're being charged in healthcare is not the same as the rate that is being paid, whether it's by the insurer or it's by the person. So one of the first things that people can do is there's a trend called DPC, which I'm very fond of here in the United States. A friend of Liberty Lovers Everywhere is an organization called the Oklahoma Surgical Center. I can't ever remember which word comes first. I think it's Oklahoma Surgery Center, which is a cash pay organization, and perhaps even take Bitcoin now. Their rates typically about 50% lower, and you have people from all over the country that fly to Oklahoma Surgery Center to get involved in surgeries at much lower cost. Another thing that people don't realize is that insurance companies, which are private businesses, negotiate with hospital providers for rates that they pay, and the hospitals are actually willing to take less than the rates that they get from private insurance, which is lower than supposedly the bill rate, if you were to pay in cash, because if you pay in cash, they avoid all the administrative costs. So a cash cost for many procedures at a hospital is much less than you would think. Then you have to understand that capitalists and free markets typically are all about character. There's various quotes from various wonderful people, including Adam Smith and various others, around character as being part of a capitalistic environment. And what you'll find is that 70% of all doctors in the United States, for example, give pro bono care to a variety of people. Hospitals give away care. In fact, most of the hospitals in the United States are private nonprofits. And oftentimes what they'll do is they'll give away care for free for many people, particularly people that are indigent or don't have money. There's also been a trend for the last few years that was started by a fairly progressive liberal talk show host that people are buying medical debt. And for a couple $1,000, you can buy millions of dollars of medical debt from people that supposedly have to pay for their health care, and they would get it for free, and it wouldn't even affect their credit rating because you're buying it, you're telling the credit company, hey, don't worry about it. We're not going to charge them. They're not in debt. So there's a lot of things going on, not only including employers, self-insured employers that are reducing healthcare costs significantly for their employees and offering it to them for free with no co-pays and no out-of-pocket expenses. So there is so much going on in healthcare, particularly around travel or choosing of specific facilities and negotiating with those facilities like you would if you purchased a car or any other large purchase. and you can reduce your costs. So it's not simple, it's complex is the answer. And the complex answer is there's so many signs of improvement, and people in the United States and other places where there's high levels of private market intensity are not typically dying on the streets.
Thank you. So maybe last questions will be from me. I don't see any other now. So during this pandemic, we saw, especially FDA, lifting some of the regulations because they understood at some point that this is slowing down the entire reaction to slow down the pandemic, to respond it. The regulation is just blocking progress, positive progress. We also saw some regulations, like state regulations about employing nurses and doctors from other states. They lifted these restrictions for labor to allow, for example, people from all over the US to work in New York. Do we see these liberalizations staying longer right now, or not so much? And what is the future of these liberalizations?
So if you don't mind, I'll tell a brief story, but it answers your question, but kind of in a roundabout way. There's this wonderful case of a facility that's been around since, I think, 1976 in India. And I'm looking at it, but I have a hard time saying the Indian name. I think it's Aravind. I think it's a famous Indian philosopher or something of that nature. Aravind Eye Care Vision Center in India. And they have done millions and millions of cases. And their model, it's a private nonprofit organization. And their model is that they let the wealthy people that want to get access to their care, which is extraordinary. It's considered some of the best care for eye care in the world. Average doctors around the world typically do, say, an average of 400, where they do 2,000. And because they do so many, they're so good. People from all around the world are willing to fly there to pay large amounts of money to get access to their care. And so they have built a business model around where they can make enough money from these wealthy people that are willing to pay to get access to the care that they give, I think it's over 60% or 50% approximately of their care away for free or very low price for indigent people. And the only thing they did differently was they separated the waiting rooms. So the waiting room for the wealthy people includes better couches, better seating areas, better food available. The waiting area for the people that are not paying for it is basically more like a bench seat, and they have to perhaps wait a little bit longer, but they still get access to this fantastic, amazing care for free. This is a model that came from the free market. Again, India has been a bastion of free market principles for many years now, ever since they decided to stop going the way of socialism. And this gives you an idea of the innovation and the models and the good things that come out of free market economies and free market principles around healthcare. I believe that in a time where, and by the way, in recorded history, typically we had pandemics about every 26, 27 years. We were expecting one. It's been like 57 years since we truly had a global pandemic, but we all knew it was going to happen. If we had embraced free market principles, we had allowed for greater intensity of ventilator systems in places like New York. We didn't have socialized medicine that has, for example, in Canada, you have to wait sometimes upwards of 20 weeks to get seen by a specialist. So these queues that are created in the NHS and UK and places like that, if we allow for greater innovation and reducing of regulatory hurdles for pharmaceuticals, all these things could have helped us move through this much faster and better, because people out there are incentivized to serve their fellow man and potentially make money and take care of themselves and their families as part of that. This is the natural way of things, and it has been since the beginning of human history.
Thank you so much. I like the optimistic outlook for the future, and great answers, great arguments. Also, a lot of good optimism, rational optimism, I think, in what you say. Thank you so much, Dr. David Vequist. It was a pleasure to host you here at Liberty International Public Zoom discussion. I want to thank everyone who joined us either through Zoom or Facebook. We had a pretty good, I think nearly around 50 people audience for today's meeting. You know, it's July 1st. It's summertime. It's early afternoon in America, but we had a really good number of people and great discussion. Thank you so much once again. I want to invite everyone to check out Liberty International's website, liberty-intl.org, to check out our Facebook, just Liberty International. You can please check out Project Arizona, projectarizona.us, and be with us. Like our Facebook page, you will see what we do. Hopefully you can join another Zoom calls. We will inform about them. Hopefully you can come to our conferences or join our online course that we will start promoting soon, the Libertarian Solutions one. Thank you, David, once again. Thank you, all the listeners. It was great to have you. And wish you good luck. Wish you amazing summertime. Goodbye.
Thank you, everyone.